Good morning, everyone. I am Dr. Asif Almas Haque. Today, we are going to discuss about right iliac fossa lump. Now, I'm sure you have come across this many times in your surgical ward, a lump in the right iliac fossa. Today, I wanted to discuss on a case of abdominal lump. Then I thought that it would be too big and it would be difficult to compress it in just 1 hour. So I think a right iliac fossa lump would be a good example of how we, as surgeons, examine the abdomen and what is going through our minds. Today, I again like to teach you in a clinically oriented manner how you'd like to take a case, deal with a case in the ward, how you like to take the history, how do you like to do the clinical examination of such a case. And now this is right iliac fossa lump is a very, very important case because be sure that if you have such a case of right iliac fossa in your ward, no matter which hospital you're in, no matter which examination you are giving, it may be MBBS, FCPS, or even card exams, the chances are great that this patient will be there in the examination. So today I would go through it in a short manner, but if you concentrate, I think the basics would be very clear to you. Okay, let's start. First, we start with the particulars of the patient. Now, particulars of the patient, age is always very, very important. Age is always very, very important. For example, what is the importance of age in a case of right iliac fossa mass? Now, if a patient, for example, of 1 year comes to you with a right iliac fossa lump, then you would probably think this is a case of intussusception, right? Similarly, if a young patient of, let's say, 20 years comes to you with a right iliac fossa lump, your first impression would be maybe this is a case of appendicular lump or maybe ileocecal TB, right? And another patient who is probably 55 years old comes to you with a lump in the right iliac fossa. Now this, you would probably think this may be a malignancy, more specifically a carcinoma of cecum, right? So this is how the age is an important factor in deciding what your diagnosis would be. Sex, male or female, very important. For example, in a case of, if a male patient comes to you with a right iliac fossa lump, you'd probably not be thinking of any gynecological diseases, right? But there are a lot of gynecological diseases that can have a right iliac fossa lump. Most commonly, a tubo-ovarian mass or abscess. These are commonly found as a right iliac fossa lump. There may be other lumps as well. Similarly, in a male patient, there is, if you find an undescended testis, it can be an undescended testis and turning into malignancy, right? So this is how male and female always differs. Make sure that you keep these differences in your mind. Then comes occupation. Now, occupation is a sign of the earnings of the patient, is the upper class, middle class, or poor patient. For example, diseases like tuberculosis are uncommon in a case in affluent families. They're more common in poor families. So occupation is always an importance. Okay. Chief complaint. Now, chief complaint certainly would be a lump in the right lump in the right lower abdomen. What the patient would say, যে doctor, আমার তলপেটে একটা চাকা পাওয়া যাচ্ছে. Probably something like this. Usually তারা চাকাই বলে, অনেকে বলে tumor. You can use the word lump. I think this is a commonly used word. It's not exactly a medical word. You can use a mass in the right right lower abdomen. Just don't say lump in the right iliac fossa in your chief complaints. Make sure that. This is very important because at undergrad level, commonly a mistake is made and it irritates the examiner very much. So make sure that you do not use any specifically medical words. The patient may also complain of pain, may have fever, may have weakness, many other things, according to the problem he or she is having. Now, what is a right iliac fossa? Now, this is the area, this is called right iliac fossa. This is the right mid-clavicular line. This is the transtubercular line, if I am correct. I think, yeah, right. This is the transtubercular line. Sorry, for a moment I forgot the name. This is the transpyloric plane. This is the transpyloric plane. This is the transtubercular plane. Now, transtubercle means the iliac tuberosity. This is the iliac bone. This is the iliac tuberosity over here. A plane that goes through the iliac tuberosity. This is the transtubercular plane. I think this is at the level of L5, and this is at the level of L1. If I have made a mistake, please correct me if I did. I think this is L5 and this is L1. So a line bounded by the right mid-clavicular line and the transtubercular plane. This is the right iliac fossa. Now, what are the things there may be? The contents, for example, the disease. What are the contents of right iliac fossa? The cecum, the ileum, the mesentery, the appendix. Mostly these are the things. So commonly their problem may be arising from the cecum, maybe from the ileum, or from the appendix. Remember, there are other problems, but as surgeons, we would mostly be concentrating on these three structures. These are some of the differential diagnoses of a right iliac fossa mass. I thought at the very beginning I'll discuss this, and then we will go into our history to make things more easier for you. Three of the most important ones are the appendicular mass, the carcinoma cecum, and the ileocecal tuberculosis. These three are the most important that you should always have in your mind. Then appendicular abscess, certainly another thing. Psoas abscess, maybe. Now, Crohn's disease is something that is also very important. Now, this would be an important differentials if you are working in England or America, because in Western countries, Crohn's disease is quite common, more common than ileocecal TB. So if you're working in a Western country or other countries, I think Crohn's disease would be the third most important differential diagnosis. Even in Bangladesh, it is quite common. Excuse me. Undescended testis, you may think about it. One thing is not over here, that you're the intussusception, right? Intussusception, ileocecal intussusception. That is something that happens in a child of probably something like 2 weeks to 2 years. Within that age, it happens. Tubo-ovarian mass is something, again, you have to concentrate on. Incisional hernia is not very common, especially in post-appendicectomy, but in my life, I have seen 2 cases of incisional hernia after appendicectomy. So that can also happen. Just remember, these are the things. I don't think, just remind yourself that abdominal wall is also part of the right iliac fossa. So if there is a lump, make sure that whether you have checked the abdominal wall as well, because the lump may be arising from the abdominal wall as well. Once I have seen one of this patient who had a trauma and had a hematoma in the abdominal wall. It looks very much like a right iliac fossa lump. So this can also be important. Okay, history of present illness. Now, history of present illness, I tell you, this can be individualized the way you want to find comfortable. You write it the way you want it. This probably would be one example. You can certainly, you can always make a better history. Remember that. Certainly you can make it in your own words and make it better. So this is what I wrote. According to the statement of the patient, he was reasonably well about 1 month back. Then he noticed a lump in the right lower abdomen, which is gradually increasing in size, associated with pain, which is colic in nature. Now, why did I say colic? It may be, remember, Colicky, maybe there is an obstructive feature over here. Ideally, usually, obstructions are very rare in case of in case of cecal malignancies or cecal growth. Why? Because the cecum is quite wide. The cecum is quite wide, and the contents are the ileal contents, which are usually fluids, right? So the chances of obstruction over here is quite rare, but colicky may be moderate, which is the pain is moderate in intensity, non-radiating, lasting for hours, no specific aggravating or relieving factor. Now, remember what is going through your mind. Whenever you get a case of right iliac fossa lump, the first three diagnoses that is in your mind are probably appendicular lump, ileocecal tuberculosis, and carcinoma cecum. So you have to take the history according to the differentials that you are thinking. What happens most of the time, you take a history which is without thinking, and then the history becomes very haphazard. The trick to take a good history is, after listening to the chief complaints, immediately you should have a couple or three or four differential diagnoses in your mind, and then questions should be depending on them. Then just don't ask all sorts of questions. If a patient comes to you with a right iliac fossa lump, don't ask the patient, sir, are you having cough or hemoptysis? I mean, definitely they may have it, but that is far away. Think of some differentials and go according to that. So whenever, for example, in this patient, when I thought a patient of 50 years old having a lump in the right iliac fossa, most likely this is a case of carcinoma cecum. So a further question was asked about whether the patient is having any unidentified anemia or blood loss. Why I say that? Because what happens is, if there is any loss from a carcinoma cecum, a blood loss from here, what happens, this blood is actually ultimately changed. It changes its character by the intestinal bacteria and other chemicals. And ultimately, when the patient passes stool, there's no sign of blood. There may just be some blackish stool. So the patient do not understand the fact that the patient is losing massive amounts of blood. That's why we say this is one of the unidentified causes of blood loss. So the patient would also complain that for the last few months, he has been increasingly feeling lethargic, for which he was hospitalized and given 2 units of blood. That means the patient had a history of blood loss, and for which he has been given 2 units of blood. I am also thinking the patient may have ileocecal tuberculosis. That's why I asked questions whether the patient is having fever. The patient is having no fever. Also, if the patient had an appendicular lump, the patient would again have fever, right? So these questions has to be asked. If the patient has appendicular abscess, the patient would have fever. So just by saying the patient had no fever, you can exclude appendicular abscess, right? Or even ileocecal TB for that matter. Yes, no history of loss of appetite, but lost about 5 kgs of weight. Now, this can happen in any case. This can happen in weight loss, can be there in any chronic disease. There may be weight loss. It may be malignancy. It may be a chronic infection like tuberculosis. It may be a chronic disease like Crohn's disease. So, but this always gives you an understanding about the health condition of this patient. Never forget to ask about the bowel and bladder habit of this patient. His bladder habit is normal, but occasionally passes dark colored stool. So this is particularly important. Dark colored stool means the denatured or chemically what the process that the blood goes through when it passes through the colon. It ultimately comes out to be a darkish stool. Remember, this is not melena. Melena is from upper abdomen. This usually may be some dark colored stool, or may not be there. It may not be there even, because very rarely I have seen dark colored stool there. Many of the patients with carcinoma cecum has no complaints about the stool colors. Okay. Past history. Now, past history, again, as I have already told you, during taking the history, you must always keep those things in your mind. What are you thinking? You're thinking appendicular lump, you're thinking appendicular abscess, tuberculosis, Crohn's disease, cecal malignancy. So questions should be according to them. For example, if you're thinking about tuberculosis, ask about previous history of tuberculosis or not. Pulmonary TB, whether the patient had a pulmonary TB, whether the patient has any long-term medication, like in tuberculosis, we take 6 or 7 months of medication. Patients, usually Crohn's disease is a chronic disease. So ask the patient, is he having any chronic abdominal conditions or not? It should support the disease like Crohn's disease. In case of malignancy, we talk about blood transfusion because this is cecum, carcinoma cecum is one of the cause of anemia, right? Hospitalizations, surgeries, these are all very important. Medications, allergic histories, these are all important. Certainly, you would like to, in case of personal history, take history of smoking and alcohol, which is not very important in the case of Bangladesh, but smoking is definitely a cause. Housing, contact with TB patients, very important. Some of the patients stay in a very cramped situation, cramped housing, and the transmission of infectious disease like tuberculosis is very common over there. Definitely history of malignancy runs in the family. Crohn's disease is another disease. I'm sorry, I've written TB here. It should not be here. TB is not a family run disease. Crohn's disease. If the patient has Crohn's disease, it can also run in the family. So take this history. This is particularly important. Again, socioeconomic status. If the patient comes from a upper rich family, usually tuberculosis is rare over there. Tuberculosis is more common in the poor families. In upper class family, malignancy may be one of the cause. Crohn's disease may be one of the cause. So this is how you can differentiate it. Sometimes this is not always there. Certainly, somebody from the upper class family may have tuberculosis, but this gives you a supportive evidence. Immunization, BCG vaccination, must take this history because the examiner will always check whether you have taken this history or not. Menstrual history, but may be important. Last menstrual period, any menstrual irregularities. Usually tubo-ovarian mass, there may be, because tubo-ovarian mass, they may arise from pelvic inflammatory diseases. So there may be some menstrual irregularities over there. So take that history. Now remember, usually in a surgical ward, it's very important that you understand these things, that in a surgical ward, you will probably not get a case of tubo-ovarian mass, right? Even if the patient is admitted into the surgery department, the patient would ultimately be referred to the gynae department, right? So if you get a case, something like this in the surgical ward, I'm talking about examinations, not in the real life. In the examinations, if you get a case, you can be sure that it's not a case of tubo-ovarian mass. But certainly, if you in the ward, in the real life, you may get a case of tubo-ovarian mass, which is quite common. General examinations, what is important? Now, all the chronic diseases, tuberculosis disease, even in malignancy, you will get a patient would have a history of loss of weight and low BMI, right? Okay, patient would definitely be ill looking with significant weight loss. Anemia, very, very important, which is very, very supportive of carcinoma cecum. Jaundice may or may not be present. Temperature, very, very important. Lymph nodes, particularly important in case of tuberculosis. So temperature is important for tuberculosis and appendicular abscess and tubo-ovarian mass. Especially in appendicular abscess and tubo-ovarian mass, there should be a high rise of temperature. High rise of temperature, and maybe associated chills and rigor. If you remember your basic pathology, that there's an abscess in your body, there's a chance of chills and rigor, right? Okay. Then the abdominal examination. What do you look? Start with inspection, right? Now let me just take this opportunity to take in inspection. What do you say? Many of you don't understand this thing. When you say in the abdomen is scaphoid, you commonly say what is the shape of the abdomen. Actually, the anterior abdominal wall, the anterior contour of the abdominal wall is scaphoid, meaning if this is the Jiffy sternum and if this is the pubic symphysis, if you run a line over here, the contour of the anterior abdominal wall is below, which looks like a boat, right? This is called scaphoid abdomen. If this is flat, you say flat. Can be rounded, which is most of the patient. It can be protuberant. Now, these are all physiological. None of them are a big problem, right? But if you get something like this with an everted umbilicus, this is a sign of ascites, right? Ascites. This is a sign of ascites. If the patient is having, this is always a case, is always a feature of all types of advanced disease. It may have advanced cecal malignancy with multiple peritoneal seedlings. It may have miliary TB. So it's always a sign of advanced disease. What else do you look for? You are looking for whether there is a mass, whether there's a visible lump. Now, there may be a visible lump over here. How to describe a lump such as this? The first thing you talk about is the site of the lump. Now, what is the site of the lump? If you draw the 9 areas, you'll see this lump is arising from, maybe involve the right iliac fossa, the right lumbar, the umbilical, also partly in the epigastric, the hypogastric, and the right hypochondriac region. So this is a huge lump. So you say there is a visible lump in the abdomen which involves all these areas. Then you measure it. What is the measurement? Measure it. Then you measure it. Width and length. These are the two things that you need. So we go for site and size. Shape, it's more or less an oval shaped mass. It may be irregular mass, because in the intra-abdominal mass, it's always difficult to understand what type of a mass it is. Maybe it looks from here, it looks like an oval shaped mass. So these are probably the things that you can take from inspection. The other things you have to go for palpation, right? Okay. Now remember, whenever you get a lump and overlying scar mark, make sure you do a cough impulse, because this may be an incisional hernia. Hernia. It may be a incisional hernia. Always do a cough impulse. Even without always remember that even without a scar, do a cough impulse, especially when there's a lump that is very visible above the abdomen. Make sure you do a cough impulse, which will exclude whether this is a hernia or any other type, because incisional hernia is not the only hernia. There are many other ventral hernias which may not have a incision, like umbilical hernia, paraumbilical hernia. Okay. Now, remember, sometimes in your ward finals, you will get a case something like this with some markings like this. Now, this is a marking which shows this is an appendicular lump. Appendicular lump. This is an appendicular lump. Why? What we are doing here, we are trying to see whether the lump is increasing in size or decreasing in size with conservative treatment. Remember, if you, I'm sure most of you remember the Ochsner Sherren regime, which we will discuss maybe in the later. If you have an appendicular lump, you initially try with Ochsner Sherren regime, which is conservative treatment and observation and monitoring. If the pain, fever, and the lump size increases, you go for surgery. If the decreases, you go for an interval appendicectomy after 6 weeks, right? That's the thing. So if there is a marking, something like that, you can just close your eyes and say this is an appendicular lump. Now, if there is an obstruction, you will see visible peristalsis, as you can see over here. Ascites we have already discussed, abdominal lump. Make sure, do not forget to check the inguinoscrotal region. Here actually the left scrotum is empty, but ideally the right scrotum should be empty in case of a right iliac fossa lump. The palpation, you know all about palpation. That starts with first, you ask the patient whether there's any pain or not. You check the temperature. You go for superficial palpation, then start with deep palpation. Now, when you start palpating your abdominal organ, make sure that you do the leg raising test or the head raising test. This is very, very important. All the examiners will look whether you have done this test or not, the head rising test or the leg rising test. Why do we do that? What happens is, now if this is an abdominal muscle, let's say rectus abdominis muscle, this is the back wall of the abdomen. There are 3 possibilities, right? One is a lump may be above the muscle, right? Another lump may be within the muscle. And another lump may be under the muscle in the abdomen, right? Now, how to differentiate at which level the lump is in? Let's say this is A, this is B, and this is C. In case of A, when you do the head rising or the leg rising, when you do the head rising or the leg rising test, A becomes more prominent. For example, if we draw a chart over here, let's say this is prominent, this is mobility, right? A becomes, on contraction of the muscle or the head rising test, A becomes more prominent and it doesn't have any effect on the mobility. In case of B, what happens when you do a head rising or the leg rising test? B becomes prominent, may become prominent, but becomes immobile. And in case of C, when you do a head rising or leg rising test, C becomes impalpable. Okay, so this is how you can differentiate between these 3 lumps, where the lump is arising from. It's a very, very important test. You must do this test at the beginning of an examination of an intra-abdominal lump. Must do this. Don't forget to do this. Okay. So what we have found out so far, we know a lump, something arising from the right iliac fossa. Size may be something like 10 centimeter by 12 centimeter, maybe irregular shape. What are the other things that we check in case of a mass? Surface, edge. Now these are not important in case of a intra-abdominal lump because surface is very difficult to, especially if the person is obese, surface would be very difficult to delineate. Edge again may be difficult. Consistency is very important. Consistency and mobility. These are the 2 things that you want to find out, right? Now, in case of the malignancy, the consistency would be hard. The consistency would be hard. It may or may not be mobile. The lump, if it's an early lump, early malignancy, or a benign pathology, then it would be mobile. If it is negative, That means an advanced malignancy. That means an advanced malignancy. Okay, so a malignant mass would be hard in consistency and most likely fixed. But in an early case, there may be some mobility. Now remember one thing, whenever you find out a lump within the abdomen, and if you are suspecting that it is a malignancy, always remember this is a sign of advanced disease. Any malignancy, in any intra-abdominal malignancy which is palpable, is always an advanced disease, always. Make sure, I mean, never say it's an early disease, no matter how mobile it is. Any abdominal lump which is palpable means it is an advanced disease, no questions asked. Okay, so we check for the different qualities of the lump. We have to check for the liver fluid trail, which we have discussed, shifting dullness, whether there's an ascites. You can do an auscultation. Never forget to do a parectal examination. Okay, now comes the salient feature. Always remember, salient features should be very concise, but just after hearing your salient feature, each and every person, all the audience must be able to say what you are thinking. That is a sign of a good salient feature. Okay, listen to this. You must include all the important positive and negative findings. Okay, let's see how it goes. Mr. X, 50 years, a farmer from Barium, was admitted with the complaints of a rapidly growing tender right iliac fossa lump with significant weight loss and occasional dark stool for 1 month. He had no fever. Now, the first line would say it's a lump. It probably is a right iliac fossa lump, which is rapidly increasing in size. Age is 50. So that means you're thinking it probably is a malignancy. You're also thinking maybe it's a tuberculosis. It may be a tuberculous mass. It may be a appendicular mass. So we say there's no fever, nausea, or vomiting. That means that excludes that you are not thinking of any appendicular pathology, because if there is an appendicitis, there should have been fever, nausea, vomiting. Appendicitis is not there. We have taken all the history of TB, whether any close contact with tuberculosis, socioeconomic status, housing of the patient, any previous history of low-grade fever or not, any long-term medication. So we are saying there's no history associated with tuberculosis. On general examination, the patient is severely anemic, which is in support of a chronic disease or a malignancy like carcinoma cecum. He has, in the abdominal examination, he has an intra-abdominal mass in the right iliac fossa, which is irregular in shape, hard and fixed. That definitely says this is a case of advanced malignancy. So what can your provisional diagnosis be? Of course, according to the finding you get, in this case, it sounds very much like a carcinoma cecum, which is advanced. I'll take a class on colonic cancers in the future, where we will discuss more about the staging and everything. Today, I like to concentrate more on the right iliac fossa mass and how to take a history. This is an example. You can customize it the way you want it. So carcinoma cecum, your provisional diagnosis can be ileocecal TB. When it would be ileocecal TB? When the patient would have history of low-grade fever, maybe previous history of pulmonary tuberculosis, contact with tuberculous patients. Sometimes bovine TB can also be there. You can take the history whether the patient is taking any bovine milk. So that can be a positive history. It can be it could have been an appendicular lump had it been a younger patient with history of severe abdominal pain, which was pain. You can describe the pain of the appendicular pain, like initial pain was periumbilical, which just shifted to the right iliac fossa. Patient should have fever. Patient should have nausea, vomiting, which the history is not over here. If the patient has high-grade fever, that would be a sign of appendicular abscess or tubo-ovarian abscess. So this is the way you differentiate it. Had it been a younger patient, like a child of 1 year, the first diagnosis would have been an ileocecal intussusception. If you examine this inguinoscrotal region and do not find a testis over there, that can certainly be an unidentified testis, maybe turning into a malignancy at this age. So there are various things accordingly. According to finding, your differential diagnosis should be something like this. These are the things. It can be an appendicular mass, which may be an abscess, which may be an appendicular lump, which may be a neoplasm. Ileocecal tuberculosis, which is the hyperplastic type. Remember this. There is two types, the ulcerative type and the hyperplastic type. The hyperplastic type usually forms lumps, and the ulcerative types may complicate itself by a perforation, intussusception, carcinoma cecum, undescended testis, transplanted kidney. Now, transplanted kidney I have not discussed. Certainly, there will be a history of transplantation, and there will be a scar mark. If you remember the transplanted kidney, where do we? Usually, the transplanted kidney is found in somewhere around the right iliac fossa, right? And there will be a scar mark over here. Okay, now investigations, very important. What investigation would you like to do? Again, investigation must be according to the findings, according to your differentials, according to your provisional diagnosis. Now, if your provisional diagnosis is carcinoma cecum, if your provisional diagnosis is ileocecal TB, if it is Crohn's disease, if it is carcinoma cecum, if it is TB, if it is Crohn's, then for all three, the first investigation should be colonoscopy and biopsy. Why? If you remember, the colon is the rectum, right? So, and this is the ileum. So the colonoscope can go all the way up to cecum very easily. This part is very easy actually. So, and if there is a mass over here, it can take a biopsy from it. Even if this TB or Crohn's disease, which mostly involve the terminal ileum, the colonoscope can also enter over here. If you have to be quite an expert colonoscopist for that, and then you can take biopsy of it as well. So for these three diseases, the number one investigation should be the colonoscopy and biopsy. Now, if you are suspecting something of an appendicular pathology, for example, an appendicular lump or abscess, then the number one investigation would be an ultrasonogram. Number one investigation would be an ultrasonogram. Now let's see, what do we see? In case of colonoscopy, you may see something like this. Sometimes the features are very diagnostic of a malignancy. You get an ulceroproliferative lesion. Sometimes the lesions, these are the visual impression is so confusing, you have no idea which is TB, malignancy, or Crohn's disease. That's why you take a biopsy. Make sure you take an adequate amount of biopsy. I usually prefer to take minimum 6 to 10 biopsies. I think this is adequate, because remember that you'd have to do a full colonoscopy in this case. Now, if you take, let's say, 3 or 4 biopsies and you don't get enough biopsy, enough tissue over here, the patient will again have to go through the pain of a colonoscopy. Not saying that the colonoscopy is a very difficult test, but why bother the patient with a second colonoscopy when you could have done that in one go? So I would prefer take 6 to 10 biopsies. And usually if you take something around 6 to 10 biopsies, I mean, I never had any problem with the biopsy, very rarely. You take a 6 to 10 biopsies and it will ideally give you a very good result. what happens when you do an ultrasound, the best thing for appendicular abscess, you will see a very nice hypoechoic. What is this? A hypoechoic area, right? Hypoechoic area. Hypoechoic area. I'm sorry for the handwriting, it's not good, I know that. So this is the hypoechoic area. What happens in an appendicular lump? You again get the mass and you can get the inflamed appendix, right? You can get the mass over here, right? You can see the mass and then the inflamed appendix. Normally, probably the appendix should have been thinner, but the inflamed edematous appendix can be seen over here. Ileocecal TB. Now, ideally, in case of the hyperplastic ileocecal TB, you get circumferential wall thickening of terminal ileum and cecum. As you can see over here, the circumferential wall thickening, you can see over here, the circumferential wall thickening, mesenteric lymphadenopathy. These are the mesenteric lymphadenopathy. Yeah, and involvement of other organs if there is a pulmonary TB. So CT scan ideally for if you want to ask what is the best investigation for this ileocecal TB or Crohn's disease, CT scan is a very good investigation. It gives you more information than an ultrasound. Oh, another thing, remember you said Psoas abscess can also be there. Sometimes you get a case of Psoas abscess and you get an you get a lump in the right iliac fossa. So very good. You can look at this in the Psoas muscle. You can see the abscess over here. This is the coronal section and this is the axial section, right? In the axial section, you can again see the Psoas abscess over here. Barium enema is another investigation which once was a very, very good investigation. Nowadays, it's replaced mostly by colonoscopy. But then again, barium enema is an investigation which will be asked in the final exams. Even in FCPS exam, in all exams, it will be asked. And what are the findings? An apple core lesion. What does it mean? The lesion is usually like this. It's annular mass. It looks something like an apple eaten by somebody. So this is called an apple core lesion. And remember, if you have always confusion, you cannot find out what it is, always a staging laparoscopy is always a very, very good investigation, because I have seen this. A staging laparoscopy was done and a patient with even colonoscopy was done, no finding was there. But in staging laparoscopy, we found out that the patient had sort of miliary TB, diffuse TB all over the peritoneum. And we took a biopsy from that and we sent it, gave the patient some antitubercular drug, and the patient became well after a few months. The patient ultimately needed a surgery, but the patient was saved when other investigations were inconclusive. So staging laparoscopy is an investigation which should always be there. You should always think about this investigation. Okay, so before I confirm my diagnosis, let's just recapitulate what are the investigations that we are thinking of. Mostly if it involves the colon or cecum, like ileocecal tuberculosis, like Crohn's disease or cecal malignancy, then the ideal investigation should be a colonoscopy, and then we take a biopsy. If it is an appendicular pathology, like appendicular abscess, appendicular lump, appendicular neoplasms, always go for ultrasound first, and then other investigations like CT scan. In case of interception, if you remember, again, ultrasound is a very good investigation. You see a donut-shaped mass. If it's even a Psoas abscess, you can do an ultrasound. You can do an ultrasound-guided drainage event for that matter. So ultrasound is always a very good investigation. You can definitely, for example, when you are posted in a difficult area, some distant area, ultrasonogram would probably an investigation available. CT scan will not be available. So always go for an ultrasound. And it's even better if you guys do a training before you are posting, you do a training on your ultrasounds and later you can practice your own when you go to your posting. So that would be very helpful for you. I think all surgeons should learn more about ultrasound. Okay. Okay. Sorry for that. Okay. So these are the most of the investigations. Let's see what other investigations. We talk about the barium meal study as well. We get the apple core, fine apple core lesions. CT scan you do. Liver function test is not very important. If you get a malignancy, serologic markers, very important. And the last investigations, if you go for surgery, fitness for anesthesia and surgery. So these are pretty much all the investigations. So in case of colon cancer, all you need to do is first to confirm. What you need to do is you need to do a colonoscopy and biopsy. When the diagnosis is confirmed, you do a staging, maybe with ultrasound and X-ray, or you can do a CT scan of abdomen and chest. You can have, these are CT scan of abdomen and chest is now more widely done in the Western world, but in Bangladesh, you always have to say ultrasound, liver function test, and the chest X-ray. These are the staging investigations done. And then other investigation according to if the patient has any comorbidities like a cardiac problem, you have to do an ECG, echo, and other investigations related to the fitness of anesthesia and surgery. Okay. So what would be a confirmed diagnosis? The confirmed diagnosis in this case would be an advanced carcinoma cecum. Advanced carcinoma cecum. Okay. So if your diagnosis is carcinoma cecum, what would you like to do? You have to do a right hemicolectomy. Remember, this is, if it's a malignancy, it's a radical surgery. It is always a radical surgery. Radical surgery. What does it mean? Radical surgery means you have to excise a wide area according to the principles of oncological clearance. Remember that term, oncological clearance. According to the principles of the oncological clearance. That means if the malignancy is over here, you have to remove a minimum of 5 centimeter distal and 5 centimeter proximal. If it is possible, 10 centimeter would have been even better. So in case of carcinoma cecum, what are the things we remove to achieve an oncological clearance? We remove the malignancy, number one, then whole of the ascending colon, and about right 1/3 of the transverse colon. So this is what we remove, and distal 20 centimeter of the terminal ileum. So what are the things we remove? We remove the ascending colon, the cecum, the appendix, the 20 centimeter of distal ileum. 20 centimeter of distal ileum. And remember the blood vessels that are supplying, like the lleocecal blood vessel, which is extra continuation of the superior mesenteric artery, right? If you remember, ileocecal artery. Then the right colic artery, okay, and sometimes the right branch of the middle colic artery, and sometimes, excuse me, hello, একটু বসেন আমি আসতেছি, জি জি জি, sorry. So you have to do an oncological clearance, you have to do a lymphovascular clearance as well. That means this artery should be excised from its origin, especially the ileocecal, the right colic. These two arteries has to be removed. So what are we removing in case of a carcinoma cecum? The ascending colon, the cecum, the appendix, 20 centimeter of the distal ileum, 20 centimeter of the distal ileum, and then the lymphovascular clearance. then do a lymphovascular clearance. That means excising the arteries supplying that particular organ from its very origin. Okay. If it's an appendicular abscess, let's say we get an appendicular abscess, what do we do? Remember, whenever you get an abscess in your body, it must always be drained. The pus cannot be there. Whether you do it in a percutaneous manner, or do a laparoscopy, or do an open surgery, you have to take the pus out of the body, no matter where it is. It can be in the brain, it can be a perianal abscess, it can be an abscess in the joint cavity. There's no role of antibiotics until and unless a very small abscess cavity. Otherwise, the abscess has to be removed from your body, always. There's no role of conservative treatment. What happens in case of an appendicular lump? Now, you all remember this term, Ochsner Sherren regime. Make sure you know the spelling correctly. Ochsner Sherren regime, you continue this regime. You start this, what are you doing in this regime? What you are doing is conservative treatment. You give the patient fluids, antibiotics, painkillers, antigastric medications, maybe antiemetics, and other things. You may catheterize the patient just for monitoring. You initially keep the patient NPO for a while. When the patient, if the patient improves, give the patient food. Continue this regime for 6 weeks. For 6 weeks. And in the meantime, always monitor the patient. You remember I showed you the picture that an appendicular lump is marked. So you mark the appendicular lump and you check whether the size of the lump is increasing, the vitals are deteriorating, pain is increasing, fever is increasing. If these things are happening, then go into surgery. If not, wait for 6 weeks and do an interval appendicectomy. Why 6 weeks? Because initially, at this point, when there is an appendicular lump, if you remember, the lump is formed by the appendix. It also has the cecum, the terminal ileum, the greater omentum, mesentery, many other things. So it's a very inflamed area, and inflamed areas are always friable. So if you want to dissect a friable area, there's always chance that injury may happen to the terminal ileum, or even worse, the cecum. That's why you don't do the surgery immediately. You wait for a while. After 6 weeks, the inflammation subsides. The inflammation subsides and tissue becomes less friable. And that is when you do the surgery. And the surgery becomes much easier at that time, and you can do it without any injury to the other organs. So that's why. So if you get an appendicular lump, what you do, you initially start conservative treatment with fluids, antibiotics, analgesics, PPI, antiemetics, and other things. You monitor the patient. What do you monitor? You monitor the size of the lump, the vital signs, pain, fever. If they are deteriorating, then you immediately go into an emergency appendicectomy. If they're stable or becoming better, then you wait for 6 weeks. And after 6 weeks, when the inflammation has subsided, then you do an interval appendicectomy. You can say appendectomy, appendicectomy, they're all correct. What happens in case of an ileocecal TB or Crohn's disease? Now remember, there is an obstruction. There is a chance that there is an obstruction. And always remember, if there is a lump that is formed in the right iliac fossa, it usually do not subside with medication. So ultimately, there is a chance of obstruction, or their patient may come to you with obstruction. In this case, you have to resect the diseased area. Now, in this case, the difference between the surgery of an ileocecal TB or Crohn's disease and the surgery of a carcinoma cecum is that in this case, in the case of TB and Crohn's disease, it is a limited resection. We say a limited right hemicolectomy. Or a limited resection. We don't have to resect, or we don't have, because we do not need to achieve the oncological clearance. Just the disease part has to be removed. So this is the part we remove, and then we anastomose the ileum with the maybe with the ascending colon. So that's what we do, ileocecal TB. But it's always easier, it's always better to anastomose the ileum with the transverse colon. Why? Because transverse colon is mobile, it can be brought down over here. Ascending colon, being the posterior abdominal wall, it is fixed to the posterior abdominal wall. That's why the anastomosis between the ileum and the ascending colon can be difficult. That's why everybody prefers to do the anastomosis with the transverse colon, because the transverse colon and the ileum both are mobile, and you can bring them close to each other and do the anastomosis. Because if you remember what an anastomosis needs, an anastomosis has to be tension free. If there's any tension in the anastomosis, it will not succeed, it will ultimately burst. You need to have a tension free anastomosis, you need to have a good blood supply, and you need to do it with the right materials, right? So a tension free anastomosis, because you need a tension free anastomosis, you may need to do an iliotransverse anastomosis. Tube-ovarian abscess, again, this is an infective mass. Start with antibiotics. If drainage is necessary, you do it. If it can be done in endovaginal, transgluteal, and other methods, I think our gynecological colleagues would be more suited to discuss on this matter. I haven't done any case of tube-ovarian mass, so I think they would be better to help you with that. If there is a Psoas abscess, again, there's an abscess. Psoas abscess, remember, this again, the incision is given like an appendicectomy. If you remember the incision of an appendicectomy incision, it's similar to that incision. And then you find the abscess cavity, drain it, put a drain over here. Usually you have to palpate the Psoas abscess. It's very simple. You don't have to enter the peritoneal cavity. The abscess is very much palpable in the right iliac fossa. Just find out an area which is dependent on bulging, most bulging area, and you'd give an incision over there and take the abscess out. Very simple procedure. Put a drain over there. Make sure that you put a wide drain over there, because more pus would be formed. And make sure you send the pus for CS, because there's a chance that it may be a tuberculosis. And then you start with anti-TB drugs. Right. Remember always a drain. Do not forget to put a drain over here. Okay. These are the basic principles. So I think that should be all about the case of lump in the right iliac fossa. I'm sure you have a lot of questions. I tried to cramp all the information I could give you in 1 hour, because I know many of you are going to prayers and you have to take shower. So I will not take a lot of your time. I think this would be helpful. If you guys have any questions, just feel free to ask me these questions. I would do my best to give you the answers. Thank you so much. And thank you for your time, and have a nice day.